Hi, everybody. Good evening, good morning, good afternoon, wherever you are. It's 7 p.m. in Paris, Frankfurt, 8 p.m. in Jerusalem, 1 p.m. in New York. And it is my great pleasure to welcome all of you to this now traditional rendezvous, I would say, of the IACH Journal Club. So I do acknowledge Takeda Oncology for their generous, unrestricted educational grant for the IACH activities. For the session of today of the Journal Club, the scientific committee of the IACH has chosen this article published in the Journal of Clinical Oncology by Dr. Christina Peters and colleagues. And we are fortunate today to have as a panelist the senior author of the work, Professor Peter Bader from Germany. And the other panelist who did not participate and is not a co-author of the Journal Club is my friend and our top expert in the field of transplant for acute leukemia, Professor Arnon Nagler from Tel Hashomer. And I think most of you are becoming familiar with the terms of reference of the Journal Club. We would choose a topic. The first or senior author of the article are invited as a panelist. Then we have an external panelist to animate, I would say, the debate. So in this phase 3 international randomized trial, this is a so-called forum trial. The question was about the value of high-dose total body irradiation for conditioning prior to allogenic stem cell transplantation in children with acute lymphoblastic leukemia who were candidates for transplant. And this is an amazing international collaborative effort asking really a key question: should we continue to use TBI as part of the conditioning, or can we safely and efficiently replace it with a chemotherapy based conditioning? So you would really appreciate this is a very important clinically impactful question. And to make a long story short, you can appreciate the results here. Well, the red curves are about the TBI-based conditioning, and you can see in the intention to treat population, there was a clear superiority in terms of overall survival of the TBI-based conditioning compared to the chemotherapy-based conditioning. And when we dig a little bit deeper, looking into event-free survival, looking into the relapse incidence, well, actually, the results were always in favor of TBI. So with this, I'd like to invite our two panelists to join me on the podium, and I would also kindly remind all of you that this is, as usual, a highly interactive activity, and please send your questions using the Q&A panel or using the chat icon, and I'll do my best to share the questions with the audience, with the panelists. And of course, I do apologize in advance if we don't have time to handle all the questions, because we know that these virtual activities are extremely popular and usually generate a lot of questions. So my first question to you, Professor Nagler, is about can you give us a brief historical overview about the value of TBI as part of the conditioning regimen in acute lymphoblastic leukemia and in general? Because we need to set the stage, I think, for this work, and then I'll go back to Professor Bader for asking him about the rationale behind this study.
So thank you, Professor Mohty, and I will start with congratulating Professor Bader for so important study, actually of 88 centers in 21 continents and 5 pediatric organizations that was planned for thousands of children. And so for me, it's amazing. So congratulations. As for TBI, we know that the transplant started at Seattle with TBI, started with an experiment on dogs. So TBI is a very good anti-leukemic modality and also very good immunosuppressive modality. And as we need in transplant immunosuppression in order to get the graft in and also to then to prevent GVHD, and we need anti-leukemic effects, this is composed in the total body irradiation. So traditionally, historically, transplant started in Seattle with Don Thomas that got the Nobel Prize with total body irradiation. And then there were experiments because the rate of the irradiation is important, the total dose, and also the fractionation. We have the story of shielding of lung or the CNS in ALL, extramedullary testis. And when we give the radiation in less fraction, so let's say in 1 fraction, so 850 rad is equivalent to 1200. But usually we are now giving the radiation, at least in adults, in 3 days, either twice a day for 3 days or once a day for 3 days. It's a bit different to various diseases, various spaces, various centers, and there was also experiments how to increase the radiation to get a stronger anti-leukemic effect and less relapse, but this was also on the cost of toxicity, and these experiments did not succeed till the dose of 1475. So we end up with 1200 usually in most of the stem cells. Also in Germany, I mean, there is just one study now that was updated in Lancet Hematology of 850. In most of, at least in adults, most of the centers are still giving a TBI for ALL, less so for AML, and because of this is mainly because of the long-term toxicity of AML, of the radiation. That was the reason for this study, especially in children, and we will allude to it, I guess, in this webinar.
But then, Peter, based on all the good things that Professor Nagler mentioned about TBI, why in this trial you try to get rid of TBI? Actually, one would think that you should keep. This is working. This is providing a good leukemia control, feasible since 50 years. So what was the rationale for your study?
So if you allow me, Mohamad, I would also like to flash back a little bit in history. So, you know, in our pediatric setting, allogeneic transplantation is well embedded in frontline treatment design as well as in relapse treatment designs. And in the 90s, we have had a very high TRM rate because only children were treated in second remission or so. The TRM rate was around 20%. And this then changed maybe when we started our first trial in 2003, when we realized by the work of John Hansen, who unfortunately passed away, and Effie Petersdorf, they published a high resolution HLA typing 10 out of 10 loci in 2002. And this was the basis for our first joint protocol in Germany, Austria, and Switzerland, where we then could show that if we use this approach, TBI, BP16, and high resolution typing, we could rescue around 70% of all the children with the toxicity TRM 10% and lower. And so these were wonderful results for the first time in a multinational, multi-center trial, showing that what could be achieved in absolutely high-risk children with ALL who need transplantation, mainly overall survival of 70%, non-relapse mortality of of 10% and lower. And then we met in Rome in front of the Forum, and this is the name for this new trial for omitting radiation under majority of age. And why? Because although we could cope with a very low rate of non-relapse mortality, there were long-term sequelae in children, and this is growth deficiencies, hormonal dysfunction induced by CNS radiation. This reduces the cognitive development of the young children. It causes deficits in intelligence, and it induces brain tumors for a long listed on the long term. And so we thought, okay, this is the biggest challenge now for us in the developing human, to reduce and get rid of this long-term toxicity which is induced by CNS irradiation. That was our aim.
So yeah, thank you, Peter. So we have a question. I mean, I have my next question to both of you is, I mean, it's clear that there is a survival advantage, whether you look to overall survival, whether you look to the intention to treat population or the treatment population, everything in the favor of TBI. So my question is, how do we explain these results, whether both of you have the same reading, I would say, and interpretation of these results? And we have a question from Dr. Francisco Barriga saying, are these results relevant to all cases of ALL, CR1, CR2, T-ALL, late relapse, early relapse, you know, just like maybe you can, Peter, clarify the subgroup analysis. My feeling, given the magnitude of difference, it's relevant everywhere, but I'd like to hear from you, both of you.
Shall I start?
Please.
Yes, that is Francesco. Thank you for this very, very important question. And in the publication we have done in the JCO, there is supplemental data. And there we have done this sophisticated analysis. And it's true, as far as the numbers did not get too small, for every subgroup, TBI, VP16, the combination was superior. And the fact that we could reduce the TRM down to 2% in the TBI setting and to 8 or 9% in the different chemotherapy arms, it has become very clear the strong potential of the combination. I would say the combination TBI, VP16. And we could show this in the 90s already, that the combination of TBI, VP16 was superior than compared to TBI cyclophosphamide, for example, which is still used, I think, in the adult conditioning. That is the combination you are using, right? And so, yes, in all subgroups, this combination was superior than chemo-based conditions.
So, Arnon, do you have the same interpretation, that it's all about very low rate of non-relapse mortality or transplant-related mortality, but also better disease control? Are we aligned on this?
For me, the results was a bit surprising, I must say, because it's all across the board and very significant difference, including in GRFS, overall survival, a bit less so in event-free survival. So there are some limitations to the study. The study was planned for 1,000 patients, and actually only 500 were recruited, and about 400 something were randomized. About 60% of the patients, 60 patients that were not randomized, there is no reason exactly but which or why they were not randomized. And also the follow-up is only 2.1 year because, of course, because of the advantage and the stopping rule of the study, so it stopped early. So we still have to look for long-term follow-up, and we need, some explanation to this limitation of the study that are discussed in the discussion. I would like to remind, and in the previous, studies, there is a registry study from pediatric group of EBMT with a bit different result, and there is an old study published in 2003 in which TBI was better for MAD but not in sibling. I didn't see in this in the JCO, maybe I missed it, including the supplement, the subgroup analysis for sibling and unrelated. So I think that these are some concerns. I want to just say that at least in adults, at the beginning in AML, for instance, when Didi Blaze at that time and Ulle Rinden compare TBI to busulfan, cyclobusulfan, there was always advantage to the TBI, but then when the busulfan were changed to IV busulfex, these advantages were gone. So here
we'll come back to the story in the adults, Arnon, but my role is to be...
there was some variability in the busulfan that could be given 1 day, 2 times a day, or 4 times a day, and also the randomization between treosulfan to busulfan. So this is a thing that was decided by the transplant coordinator. So these are the reasonings that I can give, but of course, these are the results, and they are very significant all across the board.
Arnon, I appreciate this, but my role is to be fair and maybe the devil advocate. I think the issue of follow-up, even if we have more follow-up, when it comes to transplant-related mortality, unfortunately, those patients who died will be there. So the results will not really improve, and given the difference, that's my feeling. But maybe Peter can enlighten us about this. And we have a question from Dr. Ecker for you, Peter. What is the minimum age and maximum dose of TBI when we perform transplant for children ALL, according to this study?
So if I may just come back to Arnon's remarks. So on page 25 of the supplemental data, I just looked it up. So there is for the matched sibling donor TBI, because a 2-year overall survival of 89% compared to chemotherapy 74. And this is in the hazard ratio 0.07. So it's not, it's at least a strong tendency. And you are right, in the matched donor, there is 92% with TBI overall survival, and the chemotherapy 77. So this is a clear significance at least. Okay, yes, and given your remarks to the limitations so far, this is I completely agree. So we need to have the long-term follow-up, because there are still relapses occurring also later, and we do this. The study will be continued for 5 more years. But this is in follow-up. That is that's important to mention. And
but Peter, please allow me. You're mentioning relapse, but as far as I know, of course, I'm not a pediatrician, but I read the literature. Most of the relapses would occur within the first 2 years, and we have already this follow-up. Am I wrong?
Yeah. Yes, you are right. But here we have an extremely low rate of non-relapse mortality. And this might offer more people, more patients to develop relapse later. And we don't know this yet, given that we have a TRM rate of, let's say, around 20%. It's extremely true that after 18 months, so we are confident and say, okay, it's unlikely that you will relapse. But here it might be different. But in principle, you are absolutely right.
So my next question to both of you, unless you wanted to add something, Peter.
Just answer the question of the Dr. Ecker saying what was the age. Yes, for this study, the youngest age where we started to offer irradiation was 4 years. in the study before in Germany, we used to offer radiation up the age or beginning at 2 years and older, but this was 4 years here. And yes, every child received 12 grays in 6 fractions, as Arnon mentioned and described earlier.
Okay. So we have a few other questions, but I will not be able to take them because we need to follow the flow. And there are a few questions more specific, whether people can participate in the follow-up of the study. I'll direct them to write to you, Peter.
Yes,
maybe.
yes, please do so.
So based on the results of this trial, do you believe that we are stuck now with TBI forever? You know, like this is in a stone and we will never be able to modify this. What are your thoughts, Arnon, and then Peter?
My answer is I'm not pediatrician, first of all, so I will talk in, first of all, things in ALL, I will talk adult ALL, things in ALL are changing. MRD is extremely important and disease status. Because of some of the reasons that we mentioned, both of them, MRD and disease status, were not prognostic factor in this study. And we have new drugs for ALL. We are giving today to MRD positive patient before transplant. We give usually blinatumomab because of the VOD vinotuzumab. And we have CAR T cells. And so I would say that I believe, and I guess that in the utopic world or not utopic world, our aim should be to get, as Professor Bader say, to get rid of the radiation. Because one, late effects, and then it's very technically, it's not easy. You have to schedule with the radiation, you have to admit the patient to the department only in 1 day, it's problem in the weekend. So there are also technical reasons. So I would say that with MRD monitoring, with the new formulation, with the immunotherapy, and maybe, different or we tried treosulfan, busulfan, there is clofarabine, there are other drugs. I think that we should try to get rid of the radiation. This was the goal of this study, and I would say that for me, this is still the goal.
So the case is not closed for you, and there is still room to re-challenge the use of TBI. Peter, do you agree?
Yes, and I fully agree with everything Arnon mentioned, especially the new drugs, which might change the profile and the meaning of MRD, and new techniques in MRD, the higher sensitivity of next generation sequencing MRD. And but to change the conditioning now needs an excellent setting for a prospective trial and a very good hypothesis. So, and there is a very good study running now from our colleagues in the US, from the pediatric oncology group. They are saying, okay, we do investigate whether patients who are MRD negative with the next generation sequencing, that whether these might be candidates where we can get rid of TBI, but this needs to be done very carefully because, I mean, as you can see in the remarkable event-free and overall survival plots, this setting of treatment makes a chance for 80%. I mean, I never dare to show a survival plot of 90% post-transplant in high-risk ALL patients. So this is also a promise for our patients, and I also see the chances of CAR T cells. But in childhood treatment, you know, our patients, they do develop their life, they are going to their socialization, they have to finish school, won't go to university. So that makes a difference whether you have a treatment slot of 1 year, let's say, or whether you got relapses and relapses, and you treat them, and patients fail to develop their social life. Yes, this case is not closed, but it needs controlled studies to do so. Yeah.
Okay, so apparently both of you would agree that we need to continue investigating this, the role of TBI in children, but I agree with you, the bar now is too high. So we need to ask the right question. And so my question here, well, obviously, when it comes to the elderly population, it is unlikely in adults and older patients, it's unlikely that we will jump in and do TBI 12 gray to everybody. So within the adult ALL transplant community, I think we are still stuck with chemo-based conditioning. So my question to you, Arnon, is about, is there an impact of the dose of TBI for maybe having TBI 4 gray or 6 gray? Is there a room to investigate this in a fancy, logical fashion in the adult population?
I would say that low dose TBI, 200 or 400 gray, is much less toxic. You know, the Seattle protocol for non-myeloablative is with 200 gray. But you know, we went to the chemotherapy-based protocol using treosulfan, tiotepa, melphalan, because the TBI is the schedule of TBI is not friendly, although for the low doses some dare to do without simulation, but I will not recommend this. So I would say yes, there is a place for a lower dose of TBI, let's say 400. I think that if you go above, like 500, like Russell is doing in Canada, then you are. This is the criticism for the study with 800 TBI. This is actually myeloablative for me, and the fludarabine 800 TBI, and therefore I'm more, you know, would like more to see studies in elderly or adult ALL with chemotherapy. You know, we did in the acute leukemia working party few studies with tiotepa, and 2 studies, and one of them were compared to TBI based, and there was no difference. This was a registry study. This is not randomized study. You know, the EBIM, the pediatric registry study, and this is one lesson from this study, was the results were in 3,000 patients were different than this randomized study. So we need the 2-arm studies, but still I prefer to go for chemotherapy based in the elder.
So speaking about chemotherapy, Arnon, we have a question from Dr. Farhan asking, well, you mentioned flu-bu, flu-treo. What about flu-mel? Can we gain something with flu-mel in the setting of ALL?
Yeah, we used a lot. Actually, our protocol for elderly ALL that cannot get radiation was flu-mel. So this is established protocol in ALL that we used for many years. Yes.
Okay, thank you. So Peter, going back to the issue, the main causes of failure in the chemo regimen arm in this trial are about the higher relapse rate and non-relapse mortality. I don't know exactly how we're going to sort out non-relapse mortality, but when it comes to the relapse rate, and I couldn't see it in the paper, having a sort of a systematic maintenance approach, for instance, guided by MRD or not, could this be a sort of an option for those colleagues, for instance, because obviously the results are beautiful, but if you don't have access to a radiation facility and you need to transplant the kids you are taking care of, maybe we should give some guidance how they can further optimize the result. What do you think about maintenance therapy?
Yeah, that's that's a really good point. And what we have done, for example, in patients who received chemotherapy and have had a CNS manifestation of the disease once, so they could receive 4 doses of intrathecal chemotherapy after transplantation, and this could be helpful. So maintenance chemotherapy is definitive difficult, and to apply this maybe on the basis of MRD, but to give this to every patient, this could be done. I would be hesitating, honestly, and having a targeted therapy with antibodies. So yes, this could be a chance. Binarymap, to name one. That is a trial which we are running to see in patients who enter the transplant with a high MRD load, whether they could be rescued by 1 or 2 cycles of binarymap after transplantation. Yeah, so that could be an approach, but we need to study this in a controlled fashion.
Yeah, because I think, for instance, you mentioned blinatumomab. I believe, I mean, we've been using blinatumomab in a few cases after transplant, although it may not be approved in everywhere or reimbursed. But it looks to me it's a relatively easy and safe approach after transplant. I don't recall we had any major issues with blinatumomab post-transplant. Obviously, neurotoxicity is always around.
So just to give an example about him, so we use this in patients who have had a second transplant and develop MRD positivity. So we gave blinatumomab exactly from this idea. And what happened in 2 of them? They developed a CD19 negative relapse. So
for CAR T cells, that's problematic.
Life is complicated. Life is complicated.
Professor Nagler, what are your thoughts about sort of a maintenance strategy?
So again, I will restrict myself to adult. I would say that first of all, in the school, we learn medical school that maintenance therapy is important, but this is all for ALL, less so for AML. But I would say that we today try to give maintenance therapy to high-risk leukemia after transplant with every means that we can. I guess that in children it may be more even philosophically difficult because the children want to be cured after transplant and not to be it's 4 years old or 6-year-old to continue therapy for years after transplant. But from a medical point of view, at least as adults, I guess that we should give maintenance therapies the best we can according to the mutation, to lesions, what we have, and what we can get. But yeah, I think the field is going there.
Yeah, and the blinatumomab is really very attractive. We'll not go through the details, but last week there were 2 papers in JAMA Oncology about 2 major trials, 1 positive, 1 negative, I think. But so my last question to both of you guys, and it's a $1 million question. Assuming you have Bill Gates willing to give you an unrestricted grant, unlimited amount of money, and you want to move the field of ALL forward, what would be the ideal clinical trial you would bring? And no limitation, no, please do not hesitate, just be creative. Peter.
Okay, so it was a big challenge to run this study because I was skeptical whether we would be able to randomize irradiation versus chemotherapy-based conditioning. The next challenge would be if I would have the chance to obtain enough money to run a randomized trial, allogeneic transplantation versus CAR T-cell therapy. That would be my or not only mine, but the communities wish to run such a trial.
So your ideal trial would be in those patients, just to clarify the idea, in those patients who are eligible to allo transplant in children ALL, you would randomize them allo versus CAR T cells, correct?
Okay.
Anti-CD19.
In principle, so in second CR, so we have a lot of subgroups, and there are some subgroups ideally suitable to run such a trial. It's more difficult in children who are receiving a transplant in first remission, so there is a clearly defined profile, and we need to stay to that transplant issue. But in second CR, yes, there are efforts there in our Intrial group to run such a trial, but it's extremely difficult to obtain the money to do it.
Yeah, but in my case, I told you, you have an
Oh
unrestricted
yes,
grant
that would be the study.
from Bill Gates. Okay, Arnon, what is your ideal trial in the adult population?
So I thought exactly the same. Of course, all the world is thinking about this. I think the future is immunotherapy and MRD. So as Peter, Professor Bader alluded, it's a bit more complicated than this because we need to divide the patient MRD positive or negative before the transplant and after transplant. But of course, a study in which we incorporate early on the monoclonal antibodies to achieve MRD negative, and then comparison between CAR to allo, although CAR is only given after second line today, so maybe we need to first to see how it's work on somewhat earlier before we do randomization, but in the future, yes. And then after transplantation, we also need to monitoring the CD19 and to find solution to CD19 negative relapses, which is 40% of the relapses in CAR. But to see the immunotherapy and to base the future therapy for ALL on immunotherapy.
Well, that was really a lovely and wonderful discussion, guys. I learned a lot from you. And it's quite amazing in ALL, the big advances we have seen over the last 5, 6, 7 years. I mean, for many, many years, we didn't have innovation there. And, suddenly we had the bispecific antibodies, the drug conjugate inotuzumab, CAR T cells. So the natural history, and of course in the Philadelphia positive, you have all the TK inhibitors. So it's really amazing. Obviously, we had a comment from Dr. Milovic highlighting that TALL may remain an unmet medical need, and we do acknowledge this, but hopefully there will be CAR T cells also in TLL. So that was really wonderful, guys. Thank you all. Thanks to to both of you, Professor Nagler, Professor Bader, and again, congratulations for this amazing collaborative effort. And we know how difficult it is to run these trials. So please keep going. Please, we count on you to cure all these patients. And I think the ALL model in children is really something that serves as a model in oncology in general on how we can build towards curing all the patients. Big thank you for the audience. My apologies, we're not able to take all the questions and answer them, but based on the huge number of people connected, I think this IACH Donor Club was definitely a great one. So again, thank you all very much, and wherever you are, please stay safe and keep well. Goodbye.
Yeah. Thank you very much.
Congratulations. Bye.